All right, thanks. And welcome everyone. I did say in the April webinar that if we did another one, I was going to call it the Oh No, Not Another COVID-19 Coding and Billing Update webinar. So I followed through on that one. And the way things are going, I'm imagining we'll have another one, but I'm shooting for the probably February, just to see what kind of updates come out after the first of the year or anything that might be in those final rules, so we can discuss those. And so just to let you know that the presentation was current as of right now. The CDC's or the Centers for Disease Control, their vaccine advisory panel is meeting today to discuss the newly approved vaccine, the doses and boosters, and they're supposed to be coming out with their recommendations shortly. And I am Ardith, and I am the director of the content in our VitalWare tool. So the agenda, there was an update in the diagnosis codes that's COVID related. We'll discuss that one, and then we'll go over any of the CPT and HCPCS codes that were updated, and there's several. And then we'll go into the monoclonal antibodies, it's some of the labeling information, just so that you're aware of that. And then we'll talk about the vaccine and booster updates that have come out. All right, and just so that you know, the public health emergency has been extended. The announcement was effective October 18th, so the next determination is due to come out somewhere around January 16th of next year. And this allows the flexibilities and waivers to continue. And also the some of those flexibilities and waivers, they've written it into the like the OPPS proposed rule about, and so I don't know if that's finalized yet. I'm assuming it will be, but they did put it in the inpatient rule that the flexibilities and waivers would go through the end of the, well, for inpatient, it'll be through the end of the fiscal year, and for outpatient through the end of the year. So that will get us at least through the end of 2022, and hopefully we won't have to worry about it in 2023. All right, for the diagnosis code updates, it was proposed and now it is finalized. It was effective October 1st. There is the code U09.9 for the post-COVID-19 condition unspecified. And for this, it is like a secondary diagnosis code. So you would code first the specific condition that the patient is coming in for that is that post-COVID condition. And hopefully in the documentation should link the causation effect as well. And it's to replace the B94.8 that was used previously. We did get a question in asking if there were different diagnosis codes for the variants. At this time, there is not a different diagnosis code for the variants. Usually, the different diagnosis codes will come about if there's a great need for knowing the different variants, or if there's a variation in the cost in treatment. And so I don't know if that will be forthcoming. There were some really important changes in the guidelines. So if you have a patient with a follow-up visit after their COVID-19 infection has resolved, and they don't have any residual symptoms or conditions, then you can go ahead and assign the Z09 diagnosis code, the encounter for the follow-up exam. And then also the Z86.16 for the personal history of COVID. And they have another guideline for those that do have symptoms or conditions related to that previous COVID infection. And we'll get there in a couple slides. And then for the multi-system inflammatory syndrome, they updated the sequencing because you would code the M35.81 for that multisystem inflammatory system. And then now you would code the U09.9 for the post-COVID-19 condition, which is updating and removing that B94.8. All right, so if a patient has sequela of COVID-19 or those associated symptoms or conditions that can develop following the COVID infection, then you would assign the codes for those specific symptoms, whether it could be shortness of breath, COPD, whatever that condition is, and then you would use the code U09.9. Now, the U09.9 should not be assigned for manifestations of an active current COVID infection, but they do go on into that guideline and say, but it's still possible that they can have both. So, and so here's the guideline for how to code when they have an active infection that's going on right now, and then if they do also happen to be experiencing issues from a previous COVID infection. And so I was curious because of the broad range of the different conditions that can arise with that long haulers. The Americans with Disabilities Act has been updated to say that patients, those that have long COVID or the long haulers can be considered can be a disability. And because of there are it is such a broad range, an individual assessment is going to have to be done to determine that disability, because if somebody has lost their sense of smell, that's probably not going to get them to be able to be disabled, but somebody that is not able to breathe without oxygen due to the COVID residual effects, that is a possibility there. So, and then one other update while we're in the diagnosis code section is that they are updating the process. So when people submit an application for a new diagnosis code, they are able to select whether they would like to have an April 1st effective date or an October 1st effective date for any new codes. So any code that goes through the process and is approved for that April 1st approval date, then those codes are supposed to be published in November. As of this morning, I have not seen a publication with any new codes, but I'll be keeping my eyes peeled for it. And that is giving providers time or gives vendors time to update systems or publish new books, and for for everyone that needs to be trained in the new codes to be trained. So we'll see how that process goes, and there might be additional updates, who knows? And it could be that, if they do come out with diagnosis codes for the variants, that it would be here. All right, so getting into the CPT and HCPCS updates, that these are after the April deadline. Well, in May, there were some codes published for the Novavax vaccine, or I think now they're calling it COVAX. In the United States, it is still pending the Food and Drug Administration approval, so it's not used. It was approved yesterday, I believe, for use in Indonesia. It's been received approval from the World Health Organization, and it's expected that they're going to submit for approval in the United States soon. I checked the FDA calendar site for the upcoming meeting, and I did not see Novavax on the horizon. So it's still a wait and see. But one thing that is important to note is that if there was a patient that, or if someone was in a clinical trial for the Novavax drug and got the first and second dose, they are considered to be fully vaccinated. And so if there are places where, you have to have proof of vaccine for your employer, and a patient that's had, or a person that's had the Novavax vaccine does not then have to go and get, the Moderna, Pfizer, or Johnson & Johnson to be considered fully vaccinated. They can be fully vaccinated due to the trial. But no information on third dose or booster on those. And then on August 12th, the Pfizer vaccine came out with their third dose. And I don't know if you guys remember the Irma Gerd girl, very popular memes back way back in the day. But when they released the name of the vaccine as Comirnaty, I immediately thought of her, and then lo and behold, somebody had already made a meme for it. So I thought that was kind of funny. So on August 12th, not only did they release the third dose for Pfizer, but they also released the code for the booster dose of Moderna. And so now the question becomes, well, what's the difference between a third dose and a booster dose? And we'll cover that in a little bit. All right, and in September, they released a lot of more new codes that are not active until the FDA approves. But the 004A, which is your Pfizer booster dose, did receive the emergency use authorization on September 22nd. All right, now another new code that was released in September is the Pfizer trisucralose formula vaccine, and the first, second, third, and booster codes. It is the existing Pfizer 2-dose vaccine with a slightly new formulation, eliminates the need for the diluent, and also does not require the extreme cold storage temperature. And so this is still kind of on the waiting list for approval. All right, and then October 20th, the code and approval came for, well, the Moderna vaccine was published in September, approved October 20th. So I went ahead and changed the date here on this one. For the Moderna booster vaccine, and the administration, and the formulation on that one is half of the original vaccine. And then also on October 20th, the Johnson & Johnson booster vaccine code was approved. The code wasn't released on the AMA side until October 27th. So that was kind of, gosh, I was checking I check the COVID-19 vaccine site several times a day, but I was on overdrive until the new codes were out. So, and then also they revised the code, the 0031A, the single dose. They just had to change because of the nomenclature system that's used, they changed the comma to a semicolon. So this reads the single dose, and then it would be all the same, and then booster dose for the long description for the 0034A. All right, and the 91307 was released previously, but it was given the emergency use authorization on the 29th. The 91307 and 0071A and 72A, those are the pediatric version. And so this is the advisory committee is meeting on these. So there won't be any updates to the coding or the billing, just some of the best practices for administering. All right, so now we move on to the HCPCS codes. And we have a new M code for the IV infusion of Bamlanivimab and Etesevimab. And this is for the home or the residence. And that also includes where the beneficiary's home has been made provider-based during the pandemic, because along the lines, that's also when they came out with the price increases. Woohoo! All right, May 26th, they came out with the codes for, the effective date for the Sotrovimab. So you've got the injection, and then for the drug, and then the M codes for the administration. The M0247 would be if they're at your facility or your office or your clinic, and then the M0248 is if they are in their home and they receive it. And then in June 3rd, they came out with the Casirivimab and Imdevimab, I can't say that one, because they changed the dose. And then June 8th, they came out with the M0201, which is the kind of like the, if you're at the home and you're giving the vaccine administration. And we'll be talking about this one later because they updated the instructions and how you can bill for this, like August 24th. All right. And here we've got the Tocilizumab. I hope that's how you pronounce it. So the Q is for the drug, the M is for the infusion, and I highlighted this one because the M0249 is for the first dose. And then we have the M0250 for the second dose. And just, I know this is crazy, and we've discussed it in other webinars, but these are billed under the vaccine benefit. So yes, it's bizarre, it's crazy. And I think basically it was done this way to avoid the co-payments and deductibles. But we'll talk about it a little bit more down the road. All right, and so here we've got the July 30th, we have your Casirivimab and Imdevimab, and the one I can't pronounce, where they adjusted the recommended dosage. So they came out with new codes. And then they have the M0240 and 241 for the subsequent and repeat doses. So the initial dose is still at the first one. So if you have any subsequent doses given, then you have the additional codes. All right, now for the physicians or professional billing in the audience, just as a heads up, effective 2022, there are some changes to the place of service codes. And this was in a transmittal published by CMS. It has not been released in the official files yet, but I wanted to give you a heads up because we don't have the information in the system because in our VitalWare tool yet, because we wait for those official files. But the place of service 2, which is currently just telehealth, and that's the location where the health services are provided or received. And they're going to update that to be telehealth provided other than in a patient's home. And you can see that it's just basically the same thing, but it's stating that the patient is not located in their home when receiving the health services, because there's a new one, place of service 10. and that is going to be for a telehealth provided in the patient's home. And this will not be used for Medicare patients because when we get through with the pandemic and the flavors and flexibilities, the waivers and flexibilities are over, it will revert back to the pre-pandemic regulations, which is that the patient has to be in an appropriate originating site, and that appropriate originating site is not a patient's home. It would take legislation to get that updated. So that's kind of the reasoning behind that. All right. And now on to the COVID monoclonal antibody treatments. And in May 6th, there was a price increase. So when there is an outpatient administration, so they come into your office or your clinic, the facility will receive $450 adjusted for your location and wage index and all of that fun stuff. But if you do it at the patient's home, then it's $750 because CMS was able to get price in the feedback that the $450 for doing it in the patient's home wasn't covering the costs. Now, there are two drugs for the new codes that came out, the Sotrovimab and the Tocilizumab, were not provided for free by the government. So they do have pricing information. And so for these two, you would put the drug and the administration on the claim. Where for the free ones, CMS just wants to see the administration and not the drug. All right, so June 3rd, the dosing regimen was changed to 1,200 milligrams from the 2,400 milligram. Plus, they changed how it could be administered. So they said it can be administered through the infusion or subcutaneous injection, but that should only be, that sub-Q injection is only in limited circumstances. And so that's when they released that HCPCS Q0244 for the drug. And then they updated the descriptions for the administration on the M0243 and the M0244. So no new codes for the administration, just a change in the description. All right, and then July 30th, the Casirivimab and Imdevimab, I don't know, Cassian and Imdevi, I guess, are authorized for post-exposure prophylaxis, or the PEP. So you would give the initial dose of the 1,200 milligrams, and then subsequent doses, and I misspelled doses, it's 600 milligrams once every 4 weeks of the ongoing exposure. So that's when you would use the M0243 and 244 for the first dose, and M0240 or M0241 for the subsequent dose. And then, of course, the code selection for the administration is, excuse me, is the difference between the facility or whether it's in the patient's home. All right, and then on September 16th, the Bamlanivimab and Etesevimab were authorized for the post-exposure prophylaxis, and there were no specific codes released for those, so and no additional guidance, so just use the current codes that are in place. Now, I welcome to the twilight zone on this one. An update in the inpatient prospective payment system final rule. It said that the coverage of your add-on payment for COVID-19 treatments will be paid through the end of the fiscal year that the public health emergency ends. So currently, we're looking at September 30th of 2022 for that add-on payment for the MSDRG will be there. And then kind of the crazy making part is that, excuse me, Veklury or your remdesivir was added to the new COVID-19 technology add-on payment list. So, and it was approved for about $2,028. And they also described, that the you're not going to get duplicate payment for the COVID-19 patients. So if you're receiving that 20% increase to the MSDRG for the, because they have COVID-19 and you're getting the MSDRG increase, and if you happen to give them Veklury, they're going to kind of reduce that amount by 2028, the $2,000, just so that you're not getting the duplicate payment. But the crazy making thing is that on the CMS website for the monoclonal antibody treatments, they inserted this little line on their website yesterday because CMS considers the monoclonal antibody products to be COVID-19 vaccines. They're not eligible for the NCTAP, which I guess I just don't get it. But actually, if someone, well, we'll just have to see if they come out with any information anyway. But because it is the COVID-19 vaccine, and if they do get remdesivir, it's supposed to be billed the crazy way, like you would for, the flu shot for an inpatient. You would put it on your 12X bill type and use the 771 for the preventive vaccine. And then however your MAC has you reporting the Z23 for the encounter for immunization. And so it's kind of like a plot in a storyline in a very bad novel where you're not quite sure what's going on. And so just at this point for CMS, if you're giving them remdesivir, you can, submit it under the COVID vaccine way. All right. And as a reminder, effective January 1st, 2022, you can submit COVID-19 monoclonal antibody infusions and vaccine administrations to Medicare Advantage plans. And then a little side note, the home health and hospice claims should include the condition code 78. And then on the CMS site, then they're saying effective January 1st, original Medicare will deny claims if they should go to the Medicare Advantage plans. So please, verify with those Medicare Advantage plans regarding their claim submission requirements, because although the home health and hospice original Medicare said use condition code 78 when you're submitting it to the Medicare Advantage plan, I'm not sure how the Medicare Advantage plan will want the regular non-home health and hospice claims. So, and my guess is going to be that they're all going to differ. All right, so let's, for the Casirivimab and Imdevimab, so Cassie and Debbie, of course, they have to be administered together. And what's really important is that they're supposed to be given in accordance with the authorized fact sheets and according to the regulations, the stuff that's published in the emergency use authorization. So it's used to treat mild to moderate COVID-19 in adults, pediatric patients, the 12 years of age and older, weighing at least 40 kilos, have a positive COVID viral test, and be at risk for progressing to severe COVID-19 and or hospitalization. So I'm on a support board, and this one person was saying, oh, if you get sick, go get this stuff. It's great. And everybody can have it. Well, not everybody can have it. You need to make sure that, that it's for at risk. Also, this is one of the ones where it can be given for the post-exposure. So this is for people who are not fully vaccinated, or they're, not going to be able to get that immune response up to the vaccinated, and they have been exposed to an individual with COVID, and also having that close contact criteria per CDC guidance, or who are at high risk of exposure because somebody has COVID, and they are in the same institutional setting. And they give the example here of nursing homes or prisons. And it's not authorized for pre-exposure prophylaxis for the prevention of COVID. So it's not approved for patients who are hospitalized, or patients who require oxygen therapy due to COVID-19, or patients who are going to require an increase in their baseline oxygen flow, whether that's due to COVID-19 or some other comorbid condition that requires them to be on oxygen therapy all the time. And in big bold font on the fact sheet, it says that does not replace vaccination. All right. And the Bamlanivimab and the Etesevimab is very similar, also administered together, treating patients, adults. The pediatric patients are 12 and older, weighing at least 40 kilos with that positive COVID test and at risk for progressing to severe COVID-19 or hospitalization. All right. And then it's the Bamlanivimab and Etesevimab are authorized only in some states and territories where there are a lot of variants. And so the FDA has a list of areas where it is not authorized, and that's the link. So instead of saying all the places where they are authorized, this list is just going to be where it is not authorized, and that is going to be changing. All right, now it's also for the post-exposure prophylaxis. Again, for those that are not fully vaccinated or would be like what we are calling the immunocompromised, so they're not able to get that immune response up from the vaccination, and then they have been exposed to an individual and we're in close contact, or they're at risk because of their living situation. All right, and again, not approved for the same patient population as the Casirivimab, and it is not a substitute for vaccination. All right, now we have the Sotrovimab, and again, this is the adults. The pediatrics are 12 and older, weighing at least 40 kilos, positive COVID test, at risk for progressing to more severe COVID-19 or hospitalization. And then again, not approved for those who are hospitalized. And because we were also getting questions from people of, okay, well, what if this happens? Can we bill for it now? And it's like, you need to know what the emergency use authorization says. All right, and then the Tocilizumab is a little bit different. This one is administered via infusion, and it has a different pediatric patient age range. So this is 2 years of age and older, but it does not give a weight on those. So the patient would also need to have severe COVID-19, be receiving systemic corticosteroids, and then require supplemental oxygen. And that can be non-invasive, it can be, or invasive ventilation or ECMO. All right, so, and then the maximum dosage is 800 milligrams per infusion. And then if the symptoms worsen or do not improve, then you can give one additional infusion at least 8 hours after that initial infusion. So, and this information in the quotation marks is in the information, or I found it, so I just published it here, because under the terms of the emergency use authorization, it can only be infused in the hospital setting. And it's not available to be given in the home or the residence. And so for the codes for the administration, they've only been given the one code for the administration, rather than having the two codes where there's one for, when they're in the clinic or hospital area office, and the other one is for the home, because Medicare is saying you're not going to be giving it in the home. And so there are HCPCS codes. So you would then, even though the patient is an inpatient, you would submit that 12X bill type for the facility claim. All right, and then a question that came up and that was actually published in the FAQ document by CMS, or in the documentation. Someone asked, can we administer Tocilizumab to an outpatient? And that's no, because the emergency use authorization is for hospitalized patients. Well, what if the patient came in through the emergency department and is waiting for their inpatient bed? And so the response was, well, if the patient has an order for an inpatient admission and is waiting in the emergency department bed for placement, the patient would need to be receiving the level of care of an inpatient for the administration of Tocilizumab to be covered under the emergency use authorization. So just be careful there. It has to do with the level of care that the patient's receiving. All right. So now we've got vaccines and boosters and updates and confusion about what's the difference between a third dose and the booster dose. Aren't they the same? Well, they've provided this information is kind of the definition. So what is a third dose? So when you have a patient who their initial immune response following the 2-dose primary vaccine is not sufficient to get up to the immunity level so that they're going to be considered fully vaccinated. And so that patient is going to require that third dose to be considered fully vaccinated. And those patients are going to be those that are immunocompromised or have some other type of clinical indication. And so what is a booster? Well, that is, the patient has that great immune response for their 2-dose vaccine, but the coverage has started to kind of wane over time. So I kind of think of the booster, the Wile E. Coyote on the roller skates with the rocket, just needs a boost to get over the finish line. So the initial response to the 2-dose was great, but at we're getting hopefully close to the end of the pandemic. And so we just need kind of the rocket and roller skates to shoot us across the finish line and be well. All right, so now what about mixing doses? The AMA published a CPT Assistant Special Edition for November, and they kind of addressed this, but how do you code when you're something when you're mixing doses. Well, the CDC has said that it's okay now, just kind of get what you can. But the AMA is saying, for the coding, we're not getting into the clinical scenario. Be sure you're following the current CDC guidance. But for the coding, you report the appropriate booster dose administration for the vaccine product provided, or even the third dose. So let's say they've got, the patient got the first, second, and or third vaccination of Moderna, but they got the booster of Pfizer, then you report the Pfizer booster. So it's kind of the sequence of the shot, then the manufacturer. So in our example of the Moderna vaccination with the Pfizer booster, even though that dose of Pfizer was their first one, it's really just the booster dose. So just kind of think of it as this, first, second, third booster, and go from there. And so hopefully that will cut down on some of the confusion. And and it's possible that, let's say I'm very hopeful that the clinical documentation will include whether the patient is immunocompromised, and so they're there to receive the third dose versus the booster. So, okay. So the Moderna or Pfizer, there's eligibility for the booster shot. So, but really it's very broad. So almost a lot of people are going to qualify. So 65 years of age or 65 plus, 18 years of age or older, living in a long-term care setting, or if you're 18 or older and you're working or living in high-risk settings. And so on the left-hand side, the right-hand side, have some of the occupations that they're considering high risk. So your first responders, education staff, food and agricultural workers. You can see those here. It's not an exhaustive list, because they do have the U.S. Postal Service listed here, but they did not list like FedEx or UPS. So it could be possible that those would also be considered high risk settings, especially if there's a lot of COVID still going on in your region. All right, now the medical conditions, and these are being updated, so you might want to check on them. So there's, kind of the current, the cancer, chronic kidney disease, chronic liver disease, and diabetes type 1 or 2, heart conditions, and that can include hypertension. So it can be patient-based. They've also added mental health conditions such as mood disorders or schizophrenia, because people with that are depressed also have immune response issues. So they've been added for high-risk medical conditions too. And let's see. Then the left-hand side here is the round out of the last of the medical conditions. And then the Pfizer and Moderna, you can get the booster 6 months after the second dose. For the Johnson & Johnson, they did not have a bunch of regulations like they did for the Moderna and Pfizer, such as the 65 and older or the high risk stuff. Just Johnson & Johnson, you can get the booster 2 months after the original dose. Okay, and then I believe I'm getting close to the end. Woohoo! There is this new code, the M0201. So your COVID vaccine administration inside a patient's home. And so you would report the code, the M0201, in addition to the administration of the vaccine. And so you would, when it came out in June, then you would report it once per home per date of service. And then if there was more than one Medicare patient in a single home on the same day, there were some separate instructions. But the instructions changed August 24th. So we'll go into what the current instructions are. And it's, the reimbursement is about $35 each. So after August 24th, you were to only report it if you were doing fewer than 10 patients in the same group living location. And you may report for each patient in an individual home. And then a maximum of 5 times if multiple patients are vaccinated in the same home or communal space. And to me, that was a little fuzzy, but they gave some examples, so we'll go through that when we get down here near the end. And now the patient has to have difficulty leaving the home to get the vaccine, and it could mean that they have some condition that restricts their ability to leave the home without a supportive device or help from a caregiver. They're more susceptible to contracting COVID-19. They're generally unable to leave the home, and it requires a considerable effort to get out, or their patient is hard to reach due to disability, or they face some type of clinical, socioeconomic or geographical barriers to getting the vaccine in a setting other than their home. And so just that, the patient faces challenges that significantly reduce their ability to get out and get vaccinated. Let's see. Okay, so where can this occur? So you've got your private residence, temporary lodging. So if they're at a hotel or a campground, an apartment complex, a unit in an assisted living facility, some type of group home or a non-Medicaid nursing facility. Also a Medicare patient's home that was made provider-based to the hospital. And then effective August 24th, they added communal spaces of a multi-unit or communal living arrangement and assisted living facility that's participating in the CDC's pharmacy partnership for long-term care program. Let's see. And I think I already went over this, so we may be able to get there. But just to remember that this patient has to have difficulty leaving the home, and they do not have to be certified as homebound, but the documentation should indicate, what are the difficulties that the patient has, or, kind of providing the rationale of why you're there at the home, and why, because why are they going to give you more money if it's not necessary? And so the examples that they gave was, let's say you have 2 patients that are in the same home. So you would get to report the M0201 twice. And, so you'd get $35 a piece just for that in-home administration, plus the twice for the vaccine administration. And so that would give you a total of about $150. Now, let's say you have 9 patients in the same home. That's going to give you about $535 because you would have that 9 times the $35 for the M code, and then 9 for the vaccine administration. So now if you have 12 patients in the same home, since it has hit that 10 person maximum, it's over the 10 or more, you only get to report the M0201 once, and then you're still going to get the $40 for the vaccine administration. So you're still going to get $515. So what if you have a mix? You have 5 patients in a communal space, but then you have 3 that are in individual rooms. Well, that's going to net you about $600 because you'd get to do 5 times the $35 for the patients in that communal space, plus the vaccine, and plus 3 for the in-home for those in the individual rooms, plus the admin for all 8 patients. And then I believe that's going to take us near the end. I do have the references. So the CMS COVID page, I'm there several times a day, making sure we've got everything updated. And then the guidance on the long COVID under the Disabilities Act, there's a link there if you wanted to go check it out. And then, of course, the AMA guidelines. We did not get into the coding clinic advisor this time, but they are updating that information, and there's a link. And 2 things. So here we've got the CDC guidance on the medical conditions and the high-risk occupations. And then 2 items I didn't get into was the NCCI edits, so the procedure to procedure and the medically unlikely edits. Many of those were suspended in April of 2020. I mean, it was, hundreds of thousands. And there was no timeline on when those would be reintroduced, but some of those are being slowly reintroduced on the, at the quarter. And then I also receive the Becker's, I get a daily email from them, and there are reports that hospitals, in the beginning of the pandemic, and not hospitals, that insurance companies at the beginning of the pandemic, they were waiving the co-payments or co-insurance and the deductibles for hospitalizations for COVID-19. And now they're starting to charge for those. And what they're telling the people that are having to pay is that they should have gotten vaccinated. And if they would have been vaccinated, they wouldn't have been hospitalized. And so I don't know how widespread that is. I haven't heard of anyone having that happen to them personally, but it does kind of make sense. All right, so I believe we are at the spot where we can take questions. And Marie, you may be on mute.
Can you hear me now?
I can hear you now.
Okay. Sometimes my setting gets changed. If you want to open the QA panel, Ardith, I don't want to butcher the names any more than they are already hard enough to say. So if you want to read them,
okay,
and answer them, I'll mark off if they're answered live or not.
Okay. Well, Medicare has the 0004A with a status indicator of E1. Which is not the statutorily excluded, it's like one of the excluded. So in the addendum B file, Medicare has assigned it to status indicator E1. However, on the COVID-19 vaccination page, they have assigned it to as being paid $40, just like the other vaccines. And so it's because they have the information in 2 different places. And so it is payable at the $40 rate, but they haven't come out in a transmittal and said, hey, it's this, because CMS did state that, hey, as it gets approved, we'll publish the information on our COVID-19 vaccine page, and you can use that. So in VitalWare, we are displaying the same information for 0004A for the for that, so you can see the reimbursement. All right. So all of the booster CPT codes can be used now. Well, unfortunately, no, because they have published CPT codes for, well, I would have to go back and double check the ones that say booster. So the booster for Pfizer, which is a 0004A, the booster for Moderna, and the booster for Johnson & Johnson can be used. There are a few that have been published that have not been FDA approved, and so you should not use those. Okay. Oh, goodness. This next one is, I have doctors dictating SARS pneumonia and pushing the J18.9 diagnosis code, which is kind of the generic. And so they query the doctor and ask about J12.82, and the provider says, no, just the J18.9. And so this is just and so how can I explain to the doctor that if their dictation states SARS pneumonia due to COVID-19, that the diagnosis code should be J12.82 and not J18.9? What you could do is, and this is the one we did not get to, but the AHA coding clinic advisor will probably give you some rationale that you can use and show the physician that the doctor that, hey, if they have SARS pneumonia due to COVID-19, the regulatory guidance says that this is the diagnosis code.
Okay.
Okay.
I think that's all the time that we have for today. So I think what we should do, Ardith, is take the rest of these QAs and we'll do our QA doc, and we can post that on the website within a week or so, and everybody can access the rest of the questions and answers from there.
Okay.
Awesome. And
awesome.
Lots of thank yous, great presentations, and thank you everyone for joining us today. And just a reminder, the CEU's link to the recording and presentation slides will be posted and sent out by end of day today. So look out for those. And we hope you have a great rest of your day.
All right. Thank you, everybody.